This is the third of 3 videos for chapter 15, the antimicrobial drug chapter. And before I get into the notes and stuff for this video, I wanted to just reiterate to make sure that you're watching these videos from beginning to end. If you need to take a break and stop and go do something else or whatever, that's fine. Just make sure you make it all the way through those videos so that way you're not missing any important information. Also, I will be giving information about assignments and just general directions for the class during the videos, like I did with the last video and the Cipro tab assignment. So make sure that you are watching the videos from start to end. And remember that just because we're not meeting face-to-face doesn't mean that you don't have to put in the time like you normally would if we were face-to-face, okay? I'm definitely having to put in a lot more time. Getting this stuff up and online and ready to go for you guys. I basically didn't get a spring break, which is fine. I want to make sure this is a seamless, good experience for you guys because I know you didn't sign up for this. I know you didn't necessarily want to take an online class. So I'm trying really hard to make this as painless as possible. But on the other hand, you have to do your part as well. And you may have to put in even more time than you did before. I'm trying not to design the class for that, but depending on your learning style, that might be the gist of it. So please just make sure that you're putting in the time and you're watching the videos from beginning to end and keeping up with the assignments and so forth. And if you're struggling with that, please be in contact with me and let me know and we can try to work something out, okay? So chapter 15. We will continue on. This is the slide that we left off on in the second video. And here should be where we are now, okay? So in the previous videos, we talked about any kind of drug, any kind of medical intervention has risks and benefits. And any type of antimicrobial drug needs to be chosen that's going to be what we call selectively toxic, right? It needs to be more toxic to the pathogen than it is to the host, okay? And so finding ways that drugs can selectively target prokaryotic cells like bacteria is fairly easy, right? We have different size ribosomes, they have cell walls, we don't, they have different metabolic pathways. There's a lot of different ways where we can target those cells that don't affect our eukaryotic cells. But when we get into looking at antimicrobials for eukaryotic pathogens like fungi, protozoa, parasitic worm infections, though their cells are a lot more closely designed to ours than prokaryotic cells. So targeting those is a lot harder, where there are ways we can do that, but it's just more difficult. Also, with viral infections, remember viruses take over the host cell. Okay, so the only time a virus is reproducing or replicating or metabolizing is when it's using your cell. So those aren't ways that we can target viruses because they're going to eventually kill the host cell. So developing drugs that target viruses and eukaryotic pathogens is a little trickier. And I'm just going to talk a little bit about antivirals and antiparasitic drugs. Now, antibiotics, as we would use that term in layman's terms, will not treat viral infections, right? If you get influenza virus or you get this COVID-19 thing, an antibiotic designed to kill bacteria or inhibit bacterial growth is not going to affect the virus at all, okay? So that's something I want you to remember forever and ever and ever throughout the rest of your lifetime, like put it into long-term memory. Okay, but we do have some, very few, not very many, but there are a few antiviral drugs that basically target viruses and help limit the infection. And there are some ways that we can target viruses with those drugs. And one way is to prevent viral attachment to the host cell. Whether it's a virus or prokaryotic cell, doesn't matter. If it can't attach to the host cell, it can't cause disease. So if we can create drugs that prevent them from attaching, that will limit the infection. Okay, so basically anything here in the replication cycle of a virus can be targeted. So penetration, so if it does attach, can we prevent it from penetrating or entering the host cell? Can we prevent it from uncoating and releasing its DNA or RNA? And can we prevent it from either being released or assembling the new products? Okay, so those are some ways that antimicrobials work to limit viral infections. Okay, so these antivirals are typically effective when viruses are effectively, actively replicating. Maybe some of you have had Tamiflu before. That is an antiviral that's given to treat influenza. And there's only a couple of days in the infection period that you can actually take it. If you wait too long, the Tamiflu is not going to be effective for you, or at least as effective. And that's because the viruses aren't actively replicating at such a high rate later on in the infection because the immune system has kicked in. Okay, also with latent viruses, okay, that's a term from the past. Those are difficult to treat anyway, also with antivirals or anything, because they hide in our DNA. Okay, most of the antivirals that we have today are used to treat HIV, certain herpes viruses, hepatitis, and influenza, like with the Tamiflu. Okay, people that have HIV, they take what is called a cocktail of drugs. They have a whole mixture of different antiviral drugs that they take to prevent various steps in their replication cycle. Okay, that's all I'm going to say about antivirals. Antifungals typically attack fungal cell walls, again, because we don't have those. Fungal cell membranes, they have different, what are called sterols. They have ergosterol, we have cholesterol in our cell membranes. Just a little bit different chemical there. And then fungal nucleic acid synthesis, or their DNA RNA synthesis processes. Okay, there it talks about the ergosterol. I'm going to skip some of these here and then just jump into the next unit, talking about susceptibility. Okay, antimicrobial susceptibility is basically how well does an antimicrobial work on a particular pathogen. Okay, so when it says assessing a bacterium susceptibility to antimicrobials, okay, that means does the antimicrobial work on that pathogen? Okay, one antimicrobial might work really well for E. coli, and then Staph aureus is not susceptible to it, and it's not going to treat the infection. Okay. In that same note, one of the things that we would have seen if we went to the PMC lab is how they do their susceptibility testing. So say they have a urine culture. A person may have symptoms of or signs of a urinary tract infection. They'll collect a urine sample, they'll culture it, they'll grow it, and then they'll put pieces of the specimen onto these little cards, and they'll put it in a machine. And based on metabolic profiles and different things like that, it will give you what's called a susceptibility reading, and it will tell you what antibiotics work well, what might work okay, and which ones are this particular pathogen from this particular patient is going to be, which ones are it's going to be susceptible to, which ones it might be not susceptible to, and kind of a range in the middle. So that's kind of what that means. Now, we've all heard before of antibiotic resistance, okay? And the CDC gets reports of people that have developed antimicrobial resistant infections. And in a typical year, there's over 2 million people that get like a MRSA or other type of resistant infection. And 23,000 of those people or so become mortalities. Okay, so it's important to determine antibiotic susceptibility so that the doctor's prescribing the right antibiotic, and also to kind of trace or follow the evolution of microbes to see if they're gaining more resistance to certain drugs or not. Okay, these are just some different ways that they would measure, and I'm taking that out. So antimicrobial resistance occurs when a microbe is no longer affected by a drug, okay? So if that drug is intended, if it's bacteriostatic to inhibit it, it doesn't inhibit it anymore. If it's bactericidal to kill it, it doesn't kill that particular strain of or group of bacteria anymore. And we call these resistant microbes superbugs. Maybe you've heard that before, like MRSA is an example of a superbug. And the way that these superbugs or these super infections develop is, and this is over time, this is not necessarily, you know, just one short period of time. I like to use the example of antibacterial soap. And if I remember right, we've already kind of talked a little bit about this with my niece and how she got a really bad infection because she'd used antibacterial soaps basically her whole life. But in any population, okay, of microbes, just like in any population of people, some people are more susceptible to getting sick than others, okay? Just by nature, we're all different. Same thing with microbes. You might have lots of different microbes here in this population, and some are really going to be susceptible to the drug, okay, like these here that are getting crossed off. And then others just kind of have a normal, little bit more resistance to that particular drug. And it says here also, you know, take note that some of the normal microbiota are getting killed by this as well, or at least inhibited anyway. Okay, now if you get rid of the normal microbiota through that therapy, then you have a less competitive environment for those more resistant microbes. So they're not being outcompeted by some of the other normal microbes, and now they're reproducing. Okay, and then another thing to this is that those resistant microbes, through horizontal gene transfer, like transformation, conjugation, those types of things, can pass on their resistance and share that resistance with other microbes. Okay, so this is very, very simplistic, but kind of a general sense of how that can start to develop within a patient or many patients. So we started seeing resistance start very soon after microbials became available and used. So typically what has driven this is largely due to antibiotic overuse and antibiotic misuse. Oops. USE. Okay, using antibiotics when we shouldn't, and not using them sparingly has been one of the factors that have contributed to resistance. Pathogens can gain, can gain resistance in a couple of different ways. There are some natural or intrinsic. Another word would be maybe innate, like when we've talked about the immune system in A and P. Innate, just something naturally instilled in those microbes. So like spores, those are naturally resistant to antimicrobials. Cell walls, you know, different components of the cell walls may make them naturally resistant to certain types of antibiotics. Okay. And then there's acquired resistance, where could be a mutation, an accidental random mutation that now allows this particular strain to become resistant, or through horizontal gene transfer, like we talked in the previous slide. Okay, and I'm going to skip the next couple of slides here, talking about those specifically, but just know that bacteria can naturally be resistant to some antimicrobials, and then they can gain resistance through that horizontal gene transfer. Okay, now resistance may develop because microbes can evade or hide from them, or inactivate, or basically prevent being affected by an antimicrobial. And so some ways, some of the mutations or changes, the resistance factors that they have developed over time would include things like altering the drug's target. Okay, we'll see an example of that here in just a second. But if a drug targets a particular enzyme or a particular component of the cell, they can change it just a little bit. The bacteria can change it just a little bit, so that drug will no longer affect that target. They can inactivate the drug, like we saw with the beta-lactamases, to inactivate that penicillin. And then they can either block the drug entry, prevent it from getting in, or actually pump the drug out of the cell, so there's not enough in the cell to kill that cell. And so I think this is helpful. This slide here can change the target. Rifampin, it's an A. That's an antimicrobial that's used to treat tuberculosis. This, now let me draw it a little better. This little triangle here, that's an alteration of the target. Okay, it's changed that shape here. So now the antimicrobial won't sit in here and destroy, it cannot destroy the target. Okay, that's an example there. Fluoroquinolones, they have, some bacteria have developed ways to pump it out of the cell. It can get in and can be pumped out, and so it doesn't have an effect on the drug. Some cells basically block the drug from coming in, and then like with those beta lactamases, they're going to just deactivate that penicillin, and it's no longer going to be able to function. Okay, so there's some ways that bacteria protect themselves from antibiotics. Okay, skipping through quite a few slides here, and talk about patient non-compliance. You know, getting back into what drives antibiotic resistance, what causes it. You know, the microbes are pretty good at adapting and evolving and trying to evade that selection pressure to be, no, I'm not explaining this right. Basically, the pathogens do a really good job of evolving and trying to prevent dying or prevent their reproduction from being stopped by these antibiotics. But there's things that humans do that also exacerbate or make the problem worse. And so one example of that is when patients don't finish their drug regimen, or so say you're prescribed an antibiotic and you're supposed to take one tablet twice daily for 10 days. And after day 6, you're like, I feel better. Maybe I'll just save these for later. So I don't have to go to the doctor, or I'll just take them later. Okay. Well, what that does is it doesn't completely eliminate the microbes, the more resistant microbes. Let me jump back here just a second and show you this. When you do that, if you take it only for day 6, there's a lot of these guys that are a little bit, maybe not completely resistant, but they're a little bit stronger than the others, and they've survived. And so now you've wiped out all the susceptible ones, and those a little bit more resistant ones start to hang on and live in the body. And what you might find after a few times of doing that is that that particular antibiotic just doesn't work for you anymore. So don't ever stop taking your antibiotic until you've completed that recommended time period. Okay. Missing doses, sometimes you forget, but just try to remember to do that as well. Let's see, some clinical practices, if you're going into healthcare, some things you can do to try to help prevent or limit the use of antibiotics is to check out, is it a self-limiting infection? Meaning, is it an infection that doesn't need to have an antibiotic? Can the patient get over it safely without having antibiotics? Don't prescribe or ask for medications, antibiotics, if you're not infectious. Maybe you have a rash that could be due to an injury or something like that. Don't just take antibiotics for the sake of taking antibiotics. And then also for viral infections. Okay, obviously antibiotics don't work for viral infections, so there's no use in taking them. So if your doctor says, I'm sorry, there's nothing I can do, it's just a viral infection, you'll just kind of have to try to get through it. Don't argue with them. They're trying to help you out in the long run, even though it might be frustrating. Okay. The CDC believes that about 30% of oral antibiotic prescriptions aren't really necessary. Could be due to diagnosis problems. Maybe the doctor thought it was one thing and maybe it wasn't a bacterial infection, maybe it was viral. Patients kind of throwing a fit, complaining and wanting to get a prescription even though that's not really warranted. And then also unregulated use of antimicrobials in developing countries and things like that, or maybe places where a patient can't afford taking the drug for 10 days. They can only afford to take it for 2 or 3 days, or maybe 4. And so those are some social situations that kind of play into that as well in developing countries. Okay, I'm going to skip this one. Now, since we're talking about these superbugs, it's important to note that the CDC, the Centers for Disease Control and Prevention, you probably heard a lot about them lately, has a list of the top drug-resistant pathogens in the U.S. The World Health Organization has their own list as well, looking at it on a worldwide scale. But they rank these as urgent, which is the most dire, serious, and then concerning. The urgent threats in 2017 were C. diff bacteria, okay, those that are those endospore forming bacteria, and they basically those infections show up when a person's on a pretty high power broad spectrum antibiotic, wipes out normal microbiota, and then you get the severe diarrhea. The CRE we've talked about a little bit in this chapter with the E. coli, for example, are becoming resistant. And then also the other one is Neisseria. They call it drug resistant. Neisseria, Neisseria. Gonorrhea, G-O-N-N, oops, sorry, G-O-N-O-R-R-H-O-E-A-E. Neisseria gonorrhoeae, and that's drug-resistant gonorrhea, basically. We'll talk more about that when we get into the actual diseases themselves. But those are the urgent ones in the CDC as of 3 years ago that healthcare providers are really becoming concerned about. The ones of concern, kind of in that mid-level, would be multiple drug-resistant strains of Campylobacter, Candida, which is a fungus, a yeast, Pseudomonas, Mycobacterium, Staph, and Strep. And MRSA, methicillin-resistant Staph aureus. There's also VRSA, which stands for vancomycin, which is an antimicrobial resistant as well. Okay, so patients and healthcare workers should definitely follow all drug. I'm so sorry about my handwriting on this thing. It's terrible, I know. All drug dosing instructions. Okay, again, if you're supposed to take 2 pills, take 2 pills for the prescribed number of days. If you have to do a follow-up with your doctor, do that. Properly store your medications. If they need to be refrigerated, refrigerate them. If they need to stay at room temperature, you know, keep them at that particular temperature as well. And then also not demand antibiotics. Okay, I know it can be very frustrating, but really the doctor is looking out for you for your best interest in the long run. Okay, so these are some things that patients and healthcare workers can do to prevent resistance. Okay, and I believe that's one of the things that's on your review sheet as well. I'm going to, so that's our last slide for chapter 15. That finishes up chapter 15, and I'm going to pull you back into D2L just to kind of wrap things up here just a little bit. I'm in the content section in the lecture videos. Okay, video A, video B, make sure you're watching all 3 of those. Don't forget to check out the pregnancy category and then do that Cipro tab worksheet using the PDF here. You'll have chapter 15 in mastering to do, and also an exam coming up on the 30th. If you come over here on the side, I've added an area here called daily checklist. So Wednesday, March 25th's daily checklist for Bio 204. Okay, I thought it would be helpful for you guys to kind of put a checklist for each class period so you know what is required of you for that particular class period. Okay, so for chapter 15, you'll need to make sure you've read that in the textbook, just like normal. Watch those 3 videos on Wednesday the 25th. Look over the pregnancy category PDF in D2L. Do the Cipro worksheet and upload that into the Dropbox by Friday the 27th. Okay, do that Cipro tab worksheet. And then also on Friday is the chapter 15 homework in mastering, and that's going to be due that day. Okay, now coming up next Monday, or Monday the 30th, you will have your exam. That will be in mastering. Look out for a video on the home page in D2L for that. Okay, I have your review sheet posted and should be ready to go. Okay, so that is all of the material for chapter 15. If I get a chance, I may put together a review video for the test. It's going to be chapters 8 through 10 and then chapter 15. Okay, now after the test, we'll start in and do chapters 11 through 14, which is going to be the immune system unit. Okay, so please give me a call during office hour times. Let's see, Monday and Wednesdays from 2 to 3 o'clock is the time for microbiology. So just call my office phone. That's listed on our syllabus. And if you have any other questions you'd rather email or message me through D2L, that's fine as well. Okay, so hopefully this first chapter went okay for you, and just be in contact if you need anything. Okay, we'll talk to you later.